All right, let's talk about upper abdominal pain. It's one of the most common reasons people end up seeing a doctor, but honestly, it is a master of disguise. Is it just a bad case of indigestion, or could it be something way more serious? Together, we're going to crack this clinical code.
That's really the central mystery, isn't it? The signs can be so subtle, all the organs are packed in there super tight, and getting the diagnosis right and getting it right fast is absolutely critical. So, here's our game plan. We'll start by mapping out the abdominal neighborhood to get the anatomy down. Then we'll tour the factories of digestion to see what these organs actually do. After that, we'll investigate what happens when the system gets blocked and when the chemical balance goes haywire. And finally, we'll put on our detective hats and learn how to assemble all the clues. And just a quick but really important heads up, this is all for educational purposes. It is definitely not a substitute for professional medical advice.
Okay, first things first, we have to understand the local geography. Before we can figure out what's gone wrong, we need a crystal clear map of what's where. So, the most important idea to grasp here is the plumbing. I want you to imagine two separate pipes. One is carrying digestive juices from the pancreas, and the other is carrying bile from the gallbladder. The critical thing is that these two pipes have to merge into one single channel before they can empty out. And as you're about to see, a traffic jam right at that intersection is the root cause of a whole lot of trouble. Now let's look at one of the main players here, the pancreas. It's this long gland that's kind of tucked away deep in the abdomen, right behind the stomach. Medically, we call this a retroperitoneal location. Now, why does that matter? Well, it's clinically vital because it explains why pain from pancreatitis often feels like this deep, boring pain that goes straight through to the back. It's all about location. And this slide shows that plumbing system perfectly, just in medical terms. So you've got the pancreatic duct and the common bile duct. They come together at this critical junction called the ampulla of Vater. And then there's a little muscular valve, the sphincter of Oddi, that acts like a traffic cop, controlling when the combined juices are released into the first part of the small intestine, which is called the duodenum. Okay, so now that we know the layout of the neighborhood, let's see what these factories are actually producing. What's the day-to-day job of the pancreas and the whole biliary system? You know, the pancreas is a fascinating organ because it's a total multitasker. It has two completely different jobs. Think of its exocrine part as a food processor. It makes these powerful enzymes to break down our meals. But then its endocrine part is the body's sugar controller, making hormones like insulin to manage blood glucose. One sends its products into the gut, and the other sends them straight into the blood. Two different jobs, one organ. Now, here's where it gets really clever. Look at those enzymes. You've got amylase for carbs, lipase for fats, but check out the last one, proteases for proteins. See how it says they're secreted as inactive zymogens? This is a brilliant safety feature. It's like a factory that makes scissors, but ships them with the blades locked shut. They only become active once they reach their destination in the gut. And that's what stops the pancreas from, well, digesting itself. The other key product in this neighborhood is bile. And honestly, the simplest way to think about it is as the body's own dish soap. It takes these big globules of fat from the food we eat and breaks them up into tiny, manageable droplets. The medical term is emulsification, and it's absolutely essential for absorbing fats and those critical fat-soluble vitamins, A, D, E, and K. So, we have our map, and we know what the factories are producing. Now let's dive into what happens when things go wrong, specifically when a blockage causes a major system failure. Gallstones can cause a whole range of problems, and it all comes down to where that pesky stone gets stuck. First, if it's just a temporary blockage, you get biliary colic. That's the classic pain after a fatty meal that eventually goes away. But if the stone gets permanently stuck in the gallbladder's own exit pipe, it causes inflammation and constant pain. That's cholecystitis. If that stone travels further down into the main duct, it blocks all the bile flow from the liver, and that's what causes jaundice. And finally, the worst-case scenario. If that blockage gets infected, you have a life-threatening emergency called ascending cholangitis. That stagnant bile becomes a breeding ground for bacteria, leading to a massive infection throughout the body. And jaundice, that yellowing of the skin and eyes, it isn't just one thing. When the problem is a blockage that happens after the liver, like with a gallstone, we call it post-hepatic or obstructive jaundice. And this type has classic telltale signs. Because the bile pigment can't get into the gut, the stool becomes pale. And because it all backs up into the blood and gets filtered out by the kidneys, the urine becomes very, very dark. Okay, time for a quick checkpoint to tie this all together.
Why would one tiny little stone stuck right at that final exit point, the ampulla of Vater, cause two huge problems, jaundice and pancreatitis? Well, it's because that single spot is the drain for both the bile system and the pancreatic system. A blockage there creates a 5-car pileup on both highways at the exact same time. Now let's shift gears. We've been talking about physical blockages, right? Let's move on to chemical problems, because the upper abdomen is also home to the stomach, a powerful bag of acid. And sometimes that system's balance can fail spectacularly.
Two very common culprits for pain here are GERD and peptic ulcer disease. And the key difference is actually pretty simple. GERD is a problem of direction. Acid is going the wrong way, up into the esophagus, causing heartburn. PUD, on the other hand, is a problem of defense. There's a breakdown in the protective lining of the stomach or duodenum, creating a sore or an ulcer. And that's often caused by H. pylori bacteria or certain medications like NSAIDs.
So, how do we find that H. pylori bacteria? Well, one of the most elegant tests in medicine is the urea breath test. The logic is so simple. H. pylori makes a unique enzyme called urease. So, you give the patient a drink with some special urea in it. If the bacteria are there, they'll break it down, releasing a special type of carbon dioxide that you can then measure in their breath. It's simple, non-invasive, and super accurate, as long as you remember the key rule. The patient has to stop acid-suppressing drugs 2 weeks before the test and any antibiotics 4 weeks before. All right, we've got our map, we know the factories, and we know the common ways things can break down. The final step is putting it all together. This is where the clinical detective work really begins. In any investigation, you have to know which clues you absolutely cannot ignore. These are the red flags. If a patient with abdominal pain has any of these features, it's a huge signal that something more serious could be going on, and it means you need to launch an urgent, thorough investigation, no exceptions. This quote really gets to the very heart of good clinical practice. It's so easy to jump to the most obvious conclusion, right? But the best clinicians, they force themselves to pause and ask this exact question. It's a mental tool to fight our own biases and make sure we've considered the most dangerous possibilities, even if they seem a little less likely at first. So let's put that to the test. A patient has severe right upper quadrant pain, a fever, and jaundice. Think back to the patterns we just talked about. Which diagnosis do those 3 specific signs point to? Go ahead and lock in your answer. And the answer is C, ascending cholangitis. This specific combination of 3 symptoms, fever, pain, and jaundice, is a famous clinical pattern known as Charcot's triad. Recognizing this triad is so important because it signals a true medical emergency that requires immediate, aggressive action. So we moved pretty quickly from basic anatomy, seeing those ducts as a shared highway, to the function of the pancreas and bile as these little digestive factories. We saw how a simple blockage can escalate into a life-threatening infection and how a chemical imbalance can lead to things like ulcers and reflux. And we wrapped it up with the red flags and mental tools you need for sharp detective work. What this all shows is that approaching abdominal pain isn't just about memorizing a list of facts. It's about having a system, a framework for your thinking. So the real question to leave you with is this: how will this framework change the way you approach your next patient?